especially condition like unobstructed total anomalous pulmonary venous connection, which sometimes just presents like a simple ASD with little bit of cyanosis. So I think the common defects, as I said, is tetralogy and Eisenmenger. So this is our data of older children more than 12 years of age, including all adults. And as you can see over here, of the cyanotics, we had tetralogy and Eisenmenger in reasonable share of patients. And we've started to see more and more of post-operative patients now in our OPD attendance. However, when I talk to my colleagues who are in private setup, I think more and more adults are now coming up with some kind of surgery being done in the past, almost making 40% of adults with congenital heart disease. So it's the simple rule of history, physical examination, X-ray and ECG. These are the pillars for making the diagnosis of congenital heart disease in anybody. And in adults, when we talk about a history, I think this is what we need to ask. When did the cyanosis start? Has it been the same, or it has improved, or it has increased? I think very importantly, if we want to differentiate tetralogy from Eisenmenger, then we need to see whether we need to ask specifically from the parents if there is any history suggestive of congestive heart failure in infancy in terms of failure to grow, repeated chest infections, etc. How has been the global development? Has there been any history of squatting or cyanotic spells, syncope, seizures? And then, as in any congenital case, we do ask for antenatal history, family history, etc. On examination, again, general appearance, physical development, because in straightforward tetralogy, you don't really almost making 40% of adults with congenital heart disease. So it's the simple rule of history, physical examination, X-ray and ECG. These are the pillars for making the diagnosis of congenital heart disease in anybody. And in adults, when we talk about a history, I think this is what we need to ask. When did the cyanosis start? Has it been the same, or it has improved, or it has increased? I think very importantly, if we want to differentiate tetralogy from Eisenmenger, then we need to see whether we need to ask specifically from the parents if there is any history suggestive of congestive heart failure in infancy in terms of failure to grow, repeated chest infections, etc. How has been the global development? Has there been any history of squatting or cyanotic spells, syncope, seizures? And then, as in any congenital case, we do ask for antenatal history, family history, etc. On examination, again, general appearance, physical development, because in straightforward tetralogy, you don't really expect much of delay in the physical development. Examine pulses, blood pressure, look for features of congestive heart failure. Then for cyanosis, is there any differential cyanosis? How much is the clubbing? Sometimes cyanosis may not appear very severe because the patient is anemic, but the clubbing is significant, suggesting that desaturation is likely to be more. We should take oxygen saturation in at least 3 limbs, that is 2 upper limb and lower limb. Otherwise, you will never be able to diagnose, some conditions where you can have differential cyanosis. And of course, detailed cardiac examination, where you need to look at the situs, where is the heart apex situated? Are there any pulsations elsewhere, like in the second intercostal space? What is apex beat like? Is there any left parasternal heave? And then, of course, murmurs and all. So when it comes to precordial examination, one needs to look for thoracic deformities. Many of these patients who undergone some surgery may have a scar, for example, a thoracotomy or a lateral thoracotomy scar or a sternotomy scar. Where is the apex beat? Is there a left parasternal impulse? Remember, dextrocardia may be there in some of these patients, so you have to actually palpate on the right as well as the left side. Look for thrill, systolic and diastolic. And I think second heart sound is very, very important. We've been told again and again, and I think all the students know that second heart sound sort of gives you the diagnosis in very many cases. So it's very, very important to say whether it is single, normally split, wide variable, or fixed split. It is important to hear for S2 in every case that you see during your practice. Sorry. But I think it's very difficult to, try and look for it in the exam for the first time. Then you are likely to make a lot of mistakes. So please be very, very careful and look for S2 always while you are examining in your day-to-day practice, rather than just waiting for the exam. Ejection flick, inconstant or constant, and then of course murmurs. When it comes to murmur, it is very important that you examine over the front as well as over the back, because some of these patients, especially those who have BAPCAs and all, is it there still? I think it's gone. Yes, I think now I can share.
Yeah.
Okay, great. So I'll go to the slide that I was on. Prominently, I have listed pulmonary atresia and megaly, no heart failure, not tetralogy or physiology strictly speaking. but they would also have LV dominance and they will be cyanotic heart diseases. Heterotaxy syndrome are other, which again have a very, not a very good survival to adulthood, but we have to keep that in mind. Clinical assessment of fallows, normal growth and weight gain. I've already said that when I was comparing with Eisenmenger syndrome. Cyanosis increasing on exertion, JVP not raised but may show prominent A waves, and no cardiomegaly, no heart failure, no third heart sound, no fourth heart sound, just single second heart sound and a systolic murmur. The severity of murmur depending on the severity of cyanosis, inversely related. But we must remember that in adults, rarely you may have congestive heart failure in tetralogy patients. And, I think that's another question often asked in the exam, enumerate the causes of heart failure in tetralogy of fallows. So I would give you a couple of cases as we go. This is a 28-year-old male, cyanosis since 2 years of age with shortness of breath, has been class 2, but now recently has become class 3. There is no history of squatting or spell. There is no history of recurrent LRTI or any evidence of heart failure in infancy. So if we go just by history, I think our first diagnosis should be tetralogy or one of its physiological, similar conditions. I don't think we should consider Eisenmenger, although having said that, you cannot be 100% sure because the history of infancy may not be very correctly obtained in a 28-year-old male, especially if you don't have the parents accompanying the patient. So therefore, you need to keep that also in mind. Epstein anomaly is definitely a possibility. And then rare conditions like tetralogy of like TAPVC, etc., which are obviously non-obstructive in somebody who has survived to that age. The examination in this particular patient showed that he is comfortable. His BMI is only 19, pulse was 72, pulse is all palpable, blood pressure 140/82, no respiratory distress, uniform central cyanosis with a saturation of 80% in all the 4 limbs. JVP 6 centimeter of external angle. So it is raised and the A wave is prominent. Apex beat is in the 5th left intercostal space, RV type, no left parasternal heave, single second heart sound, and a loud grade 3/6 ejection systolic murmur at the 3rd and 4th left intercostal space, which is radiating to the back. Lungs are clear, liver is 2 centimeter. So I think we are pretty sure that the diagnosis is likely to be tetralogy of fallows. We will not consider Eisenmenger syndrome or Epstein's because there is a loud systolic murmur at the 3rd and 4th intercostal space, which is grade 3/6, and therefore we should discard these possibilities. But then there is an odd finding for tetralogy, and which is presence of heart failure, because we saw JVP was 6 centimeter and liver was 2 centimeter below the costal margin. So the question is, what are the causes of heart failure in tetralogy or tetralogy physiology? And I think this is more likely to happen in adults beyond the age of maybe 20 or something. And that could be primarily because of severe hypoxia producing ventricular dysfunction, which could be right and left, but generally right is worse than the left ventricle. Or the VSD may have restricted, producing RV hypertension, which is suprasystemic, and now RV is failing. Or it could be secondary to infective endocarditis, severe aortic regurgitation, because we know the aorta is abnormal, very dilated, and tends to have, all the adults with tetralogy may have some amount of aortic regurgitation. Systemic hypertension is a very common problem. Whether it is more common in cyanotic is something that we don't have a proven record, but some people believe that yes, it is more common. And sometimes you can have very large collaterals or patent ductus arteriosus producing heart failure. Remember, large MAPCAs is a rare cause of heart failure, because very often when you ask in the exam cause of heart failure, the first answer is large MAPCA. So that's a rare cause of heart failure. Sometimes a very large shunt, especially done in infancy, can produce heart failure over a period of time, and there could be some very unusual reasons like anemia and all. This is a slide that I think has been partly shown by Dr. Saurabh, but I will beyond the age of maybe 20 or something. And that could be primarily because of severe hypoxia producing ventricular dysfunction, which could be right and left, but generally right is worse than the left ventricle. Or the VSD may have restricted, producing RV hypertension, which is suprasystemic, and now RV is failing. Or it could be secondary to infective endocarditis, severe aortic regurgitation, because we know the aorta is abnormal, very dilated, and tends to have, all the adults with tetralogy may have some amount of aortic regurgitation. Systemic hypertension is a very common problem. Whether it is more common in cyanotic is something that we don't have a proven record, but some people believe that yes, it is more common. And sometimes you can have very large collaterals or patent ductus arteriosus producing heart failure. Remember, large MAPCAs is a rare cause of heart failure, because very often when you ask in the exam cause of heart failure, the first answer is large MAPCA. So that's a rare cause of heart failure. sometimes a very large shunt, especially done in infancy, can produce heart failure over a period of time. And there could be some very unusual reasons like anemia and all. This is a slide that I think has been partly shown by Dr. Saurabh, but I will just try and highlight on physical examination, how can you sort of differentiate tetralogy from others. For example, if you have a prominent A wave, you may be dealing with triology and not tetralogy, but in adulthood, you may have prominent A waves, and tricuspid atresia, especially if the ASD is a little restrictive, will give you prominent A waves. LV type of apex, predominantly in tricuspid atresia and single ventricle. The third cause could be double outlet right ventricle, where the VSD is restrictive and LV has only this as an outlet, and therefore it hypertrophies. Pulsations in the second intercostal space and dull second intercostal space tells you about corrected transposition, or single ventricle where the outflows are inverted. And if you have parasternal heave, which is prominent, which is not a feature of tetralogy, you have to again think about either a triology or with VSD restriction. Dextrocardia, mesocardia with situs solita. That means a mismatch between the visceral and the cardiac situs. Always think of CTGA, VSD-PS. You're going to be correct 80% of the time. AV valve regurgitation, again, suggests AV septal defect or CCTGA. Seesaw murmur of left upper, along the left upper sternal border, topped with absent pulmonary valve, because there is PS and PR. Remember, this PR murmur is low pressure PR and not high pressure PR. Complete heart block, think about CCTGA and heterotaxy syndrome. And again, I think as Dr. Saurabh very nicely pointed out, that if you have a mismatch between the murmur and the cyanosis, that means you have a prominent murmur and significant cyanosis. Think about admixture lesion, which have developed pulmonary stenosis. Typical ECG, I think in our case, very clearly showing you right axis deviation, right ventricular hypertrophy, and an early transition, as pointed out by Arrow in V2, suggests that this is tetralogy. X-ray shows no cardiomegaly, pulmonary oligemia. It may not show very typical boot-shaped heart in everybody, but I think absence of cardiomegaly, pulmonary oligemia with not a prominent pulmonary artery segment gives you that this could be compatible with tetralogy. So this patient had most likely tetralogy of Fallot's itself. However, if his ECG or somebody else's ECG, which looks like tetralogy, shows this, that is left axis deviation and only left ventricular hypertrophy, and you can see that the atrial waves are also very, very prominent, because in adults, the right atrium may get very enlarged in patients of tricuspid atresia. So think about tricuspid atresia in such cases. Complete heart block, I've already said that you need to think about CCTGA with VSD-PS, because it's almost, if it is present, it's very helpful. If it is not present, of course, it doesn't really work that way. So typical tetralogy of Fallot's X-ray, we know, is a boot-shaped heart, upturned apex, RV apex, pulmonary oligemia, pulmonary bay, and a right-sided aortic arch. But remember, typical X-ray you may not get in all the conditions, in all these conditions. Therefore, if they are there, they are helpful. But if they are not, I think you should not disregard the diagnosis. So this is typical X-ray of tricuspid atresia, where you have an LV apex and an RA cutoff sign because of juxtaposition of the RA appendages. You may have a box-shaped heart or a hump on the left border in a single ventricle, again being caused by the inverted infundibulum. And this is very, very typical that you have a situs solitus, but with dextrocardia or mesocardia, and a prominent hump on this side, which is caused by very dilated aorta or L post aorta. And this is quite typical of CTGA, VSD-PS. So it may give you a clue as to which diagnosis you are dealing with if you combine clinical examination, X-ray, and ECG, all three. Now, this is an ECG which is very different from a tetralogy ECG. This also shows right axis deviation, right ventricular hypertrophy, but the prominent part is that you have STT changes and you have no early transition. So it's actually a late transition, and this is quite typical of so-called triology or a severe pulmonary stenosis with intact ventricular septum, or can also be seen with restrictive VSD because RV pressure goes suprasystemic there also. So I'm not going to spend much time on this slide because I think this has been again told to you, but this is again a common question asked in the exam, that why it is tetralogy and why not ASD and PS. And I think the answer will be that left parasternal heave has to be more prominent in triology. JVP will show more prominent A waves. JVP may actually be raised, especially if RV is dysfunctional. S2, P2 may be heard as a delayed soft component of second heart sound. You may get pulmonary ejection click, which is inconstant, whereas in tetralogy, the click is constant, which is aortic. Because in triology, the obstructions at the valve level. And of course, you have murmur, which is proportional to the severity of cyanosis and not inversely proportional like you have here. And ECG, I already showed you, will show prominent RVS, late transition, and STT changes of strain. X-ray may show you cardiomegaly, but pulmonary artery segment is going to be dilated because of the valvular component of the pulmonary stenosis in ASD and PS. The second common disease that we see in adults is Eisenmenger syndrome, which I think is very well defined for a long time, where we expect the shunt to be reversed or bidirectional. So it can be, may not be always right to left, it could be bidirectional also. So what is the difference between tetralogy and Eisenmenger physiology? I think in tetralogy, there's an anatomic obstruction leading to reduced pulmonary blood flow. The pulmonary artery pressures are normal or less than normal. On the other hand, in Eisenmenger syndrome, also the pulmonary blood flow is reduced, but that is reduced because of the high pulmonary vascular resistance offered by the capillaries of the pulmonary vasculature, and therefore the pulmonary artery pressures are actually severely elevated. They are systemic in a VSD or a PDA, so they are systemic. So Eisenmenger syndrome also has low pulmonary blood flow, and that is an important thing to remember. It doesn't fall into the category of high flow. The pressures are high, but the flow is reduced. We all know it is most often secondary to large ventricular septal defect or a large PTA. AP window is a relatively rare disease, but it can produce very early Eisenmenger syndrome. ASD, I think a lot of people believe does not produce Eisenmenger physiology. It is a coincidental PAH and ASD. So we don't know whether ASD goes into Eisenmenger, but yes, most of the books will say that in the 4th or 5th decade, they can go into Eisenmenger. And then we have another huge group of cyanotic heart disease, which may go into Eisenmenger if they survive. They have a very poor survival. So exceptionally, some of them survive and they may go into Eisenmenger physiology as well. X-ray of Eisenmenger, I already showed you one prominent pulmonary artery segment, absence of cardiomegaly, central plethora, peripheral, or leukemia. The question asked is often, how do you differentiate whether it is VSD Eisenmenger, PD Eisenmenger, or ASD Eisenmenger? And I think that's a common scenario in the exam. So I think this table just highlights some of the points. The age of onset is earlier in VSD PDA. It is much later, as I told you, for ASD. And differential cyanosis. Differential cyanosis is very, very helpful if present. But remember, in 50% of PDAs, it is not present. So if it is present, it's very helpful. And you must make sure that you put the right hand with one of the foot to one of the feet to see whether there's differential cyanosis or not. Unless you put it side by side, you may not appreciate the difference very much. Or of course, you can always do pulse oximetry to see the difference. In ASD, you will have cardiomegaly. But I think the best differentiation is by the second heart sound, and this is what has been there for a very long time, in Paul Wood series also, that if you have a single second sound, you call it VSD. If you have a narrow split or a normal split, call it PDA. If it is wide and fixed, it will be ASD. Parasternal heave, unlikely in VSD PDA because the RV pressure never goes beyond LV pressures. And similarly, tricuspid regurgitation murmur may be there in ASD because right ventricular dilatation is much more in ASD compared to the other two conditions. Pulmonary regurgitation murmur is secondary to PAH and can occur in any of the conditions, but it is typically described in PDA. So if you have a PR murmur in an Eisenmenger, please make a diagnosis of patent ductus arteriosus. This is a 25-year-old lady who's recently married, has presented with mild dyspnea and fatigue. She's very minimally cyanosed. In fact, parents or the family did not even pick up cyanosis. There's no evidence of heart failure. First heart sound is normal. Second heart sound is single. There is no murmur. What is the diagnosis? I think we would put it as Eisenmenger. Because there is no murmur, one can think about pulmonary atresia with VSD. But remember, pulmonary atresia with VSD survival is not so good. And secondly, they are likely to be more blue unless they have really large MAPCAs. But if there are large MAPCAs, they will produce murmur also. So most likely the diagnosis is Eisenmenger syndrome. This is the X-ray. You can see that typically Eisenmenger syndrome X-ray. The question is, what is the level of the shunt? Whether it was a ASD, BSD, PDA, or AP window or any other. And as I said that we go often by the second heart sound, and you can see the second heart sound being single goes more in favor of a ventricular septal defect. However, by X-ray also you may get a clue. For example, in ASD Eisenmenger, you will have clean VSD PDA because the RV pressure never goes beyond LV pressures. And similarly, tricuspid regurgitation murmur may be there in ASD because right ventricular dilatation is much more in ASD compared to the other two conditions. Pulmonary regurgitation murmur is secondary to PAH and can occur in any of the conditions, but it is typically described in PDA. So if you have a PR murmur in an Eisenmenger, please make a diagnosis of patent ductus arteriosus. This is a 25-year-old lady who's recently married, has presented with mild dyspnea and fatigue. She's very minimally cyanosed. In fact, parents or the family did not even pick up cyanosis. There's no evidence of heart failure. First heart sound is normal. Second heart sound is single. There is no murmur. What is the diagnosis? I think we would put it as Eisenmenger. Because there is no murmur, one can think about pulmonary atresia with PSD. But remember, pulmonary atresia with PSD survival is not so good. And secondly, they are likely to be more blue unless they have really large MAPCAs. But if there are large MAPCAs, they will produce murmur also. So most likely the diagnosis is Eisenmenger syndrome. This is the X-ray. You can see that typically Eisenmenger syndrome X-ray. The question is, what is the level of the shunt? Whether it was ASD, BSD, PD, or AP window, or any other. And as I said, that we go often by the second heart sound, and you can see the second heart sound being single goes more in favor of a ventricular septal defect. However, by X-ray also you may get a clue. For example, in ASD Eisenmenger, you will have cardiomegaly and you will have right atrial enlargement as shown over here. In a PDA, you will have very prominent pulmonary artery segment, but in addition, the aorta will also be prominent because the PDA is over here. So the aorta also tends to be prominent. And in a BSD, you may get some amount of left ventricle and left atrial dilatation, but there's no right atrial dilatation, no aortic dilatation. So you can differentiate to some extent by X-ray chest, but of course, it doesn't have very good sensitivity. ECG typically will show whatever the lesion may be, right axis deviation, right ventricular hypertrophy. However, if there are prominent LV forces, especially if the patient is clinically not blue, I think you must not make them Eisenmenger syndrome. You must think about whether this patient may still be operable, and therefore you may have to go on for further tests like cardiac aspiration, etc. But only if there are good LV forces, because that is what you expect in a VSD PDA. If there is a left to right shunt still happening, LV should stay volume loaded. So the same lady, you can see the contrast echo, and I think it's quite obvious that there is a little bit of contrast going from the right ventricle to the left ventricle across a VSD. The question is, because she's recently married, nobody knew that she has this disease. Family is very keen to have a baby. She's only class 2, very little symptomatic. The question is, should we allow her to get pregnant? Unfortunately, I can't ask you that question but most of the time, I think we all know that Eisenmenger syndromes are very, very high risk for pregnancy, and therefore pregnancy is actually contraindicated according to the latest guidelines that have been published in European Society of Cardiology of pregnancy with heart disease. And this is categorized as modified WHO risk class 4, and it's actually a contraindication. And we need to tell them right there and then that no, it has a very high maternal mortality. And I think the family generally would be very keen, and therefore we have to counsel them very well. So much so that if the pregnancy occurs, even termination has to be discussed unless they come beyond the stage of termination. This is an 18-year-old man presenting with palpitations, minimal cyanosis, no heart failure, widespread second heart sound, and a short systolic murmur. And I think when we say widespread second heart sound in a cyanotic adult, these are the list of conditions that come to our mind. Of these, abstinence anomaly is quite likely because patient is again very little symptomatic, just with palpitations. Of course, remember, very large AST can also give you mild cyanosis even without undergoing Eisenmenger reaction. So very large AST, because of mixing like a common agent, can give you mild cyanosis. TAPVC unobstructed can also give you widespread second heart sound. And then there are rare conditions like ASD with IVC blood streaming into LA or left SVC going into coronary sinus. And rarely anomalous systemic venous drainage can also give you cyanosis when there is a ASD also. So this is cardiomegaly, quite a big heart, but patient is not in failure. And the ECG is quite typical of abstinence anomaly. So X-ray and ECG almost gives you the diagnosis right there and then. But sometimes you may have a very typical X-ray, like a figure of 8, and that's not uncommon in adults with supracardiac TAPVC, that you get typical snowman's heart, and then the diagnosis is quite obvious. So cardiomegaly, snowman's heart, plethora. I think whenever you have cardiomegaly on X-ray chest but no CHF, you have to think of these conditions, which I've just enumerated. Is again very little symptomatic, just with palpitations. Of course, remember, very large AST can also give you mild cyanosis even without undergoing Eisenmenger reaction. So very large AST, because of mixing like a common agent, can give you mild cyanosis. TAPVC unobstructed can also give you widespread second heart sound. And then there are rare conditions like ASD with IVC blood streaming into LA or left SVC going into coronary sinus. And rarely anomalous systemic venous drainage can also give you cyanosis when there is a ASD also. So this is cardiomegaly, quite a big heart, but patient is not in failure. And the ECG is quite typical of abstinence anomaly. So X-ray and ECG almost gives you the diagnosis right there and then. But sometimes you may have a very typical X-ray, like a figure of 8, and that's not uncommon in adults with supracardiac PAPVC, that you get typical snowman's heart, and then the diagnosis is quite obvious. So cardiomegaly, snowman's heart, plethora. I think whenever you have cardiomegaly on X-ray chest but no CHF, you have to think of these conditions, which I've just enumerated. I'm just going to show you one of maybe one or two more cases. This is an 18-year-old girl with deep cyanosis, having dyspnea and fatigue since early childhood. 18-year-old, but deeply cyanosed. You can see saturation of 60%, still not in heart failure, has an RV impulse, which is grade 2, single second heart sound, no murmur, right axis division, right ventricular hypertrophy. I think we are going to diagnose this girl as VSD pulmonary atresia because she's very blue and she has no murmur, or maybe a very severe tetralogy of Fallows. Could be Eisenmenger, but unlikely unless we say Eisenmenger to one of the complex heart diseases. But I think the clue is that RV impulse is quite a lot. So suggesting that her RV pressure is going to be more than LV pressure, and therefore a large VSD is very unlikely in this situation. This is the X-ray, which clearly tells you that there is increased vascularity, although cardiomegaly is not there, plethora is there, and pulmonary artery segment is prominent. To our surprise, her X-ray, echocardiography showed a normal 4-chamber view, a large AST. But what is important is that the vessel which is arising from the left ventricle is actually dividing into 2 branches, and the vessel which is arising from right ventricle is not dividing into branches. So this is aorta. Aorta is from RV, pulmonary artery is from LV, and there is a large AST, and that is what has kept her alive, although at a very deep cyanotic level. But it's not uncommon to see these patients coming from rural background where they don't even seek any medical attention for a long time. But now she became very symptomatic, and that's how she came. So this is, one of the exceptional survivors of complex CSD, which I'm sure all of us are going to see and all of us see in our practice. Although I think if you think about Western literature, they wouldn't be seeing such patients, but we do sometimes see complex heart disease, which have a very high mortality in infancy, still coming to us during adult life. So please don't close your eyes to these rare conditions also. Sometimes these things can also come to our attention. 22-year-old boy who came to us with hemoptysis. This is actually, I think about a year ago. Recurrent hemoptysis for the last 2 years. We've done APC coiling several times. He was cyanosed since 6 months of age, BT shunt at 18 months, Glenn at 5 years. Gradually increasing cyanosis. We catheterized her when we found that the pulmonary arteries are quite small and not suitable for content surgery. Saturations were quite low. X-ray shows quite a significant patch on the left side. ECG is suggestive of complex underlying heart disease. And the issue is why he's having increasing cyanosis and why he's hemoptizing. So increasing cyanosis, I think, is a natural phenomena following Glenn. As the patients get into their adult life, the IVC contribution to the systemic venous flow increases, and therefore their cyanosis worsens. So Glenn may be quite comfortable till 5, 6, 7, 8 years of age, but during adulthood, even a perfectly functioning Glenn will become more and more blue. And then on top of that, they can also develop pulmonary AV fistulae. And these patients may have hemoptysis from collaterals, from pulmonary fistulae, or even sometimes associated with pulmonary tuberculosis. I think we've all seen these cases quite often in our practice. But this patient had really large pulmonary fistulae which needed to be closed with a vascular plug. I think finally, cyanosis with absolutely normal cardiac examination. I think we all know the causes: total anomalous systemic venous drainage, unroofed coronary sinus left SVC draining into LA, and pulmonary V malformation. So examination is normal. ECG may also be normal, but the child is blue. And I think the diagnosis is quite easy to do with a contrast echo. So pulmonary AV malformations are congenital in most cases, can develop post-Glenn. I think rare cause of pulmonary malformation is epidermal malformation, and these are the rare causes that I have listed. And echo with saline contrast injection, I think we all know, is quite diagnostic, even if clinical, X-ray, ECG, everything is normal. So to summarize, I will just give you 4 scenarios. No left parasternal heave, single second heart sound, good ejection systolic, murmur at the left sternal border, middle and lower. Think about tetralogy. Quiet precordium, multiple sounds, very soft murmurs. Think about abstinence. Left parasternal heave with a wide fixed S2 with P2 audible, ejection systolic murmur, and flow MDM at the lower left sternal border. Think about like findings of ASD, basically. Think about TAPVC. And finally, no left parasternal heave, single second sound, but